Hello, everyone. My name is Dr. Patrick McGrath, and I'm the Chief Clinical Officer for NOCD. NOCD is a teletherapy for obsessive compulsive and related conditions. If you think you might be struggling with OCD or other related conditions, check us out at nocd.com. That's NOCD.com. And if you like the Get to Know OCD podcast, what we're doing here today, you can subscribe on the NOCD YouTube channel or anywhere where you get your favorite podcasts. I'm excited today to be joined by colleagues of mine from NOCD, Dr. Jamie Fiesner and Dr. Sarah Conley. I'm going to give them a few moments to say a little bit about themselves, and then we're going to dive into our new study that's coming out about the child and adolescent work that we do through NOCD. So, Jamie, can you start off and tell everybody a little bit about you?
Yeah, thanks, Patrick. So I'm Jamie Fiesner, and I'm a psychiatrist. I'm the chief medical officer at NOCD. I've been with NOCD for over 6 years now, and I'm also a professor of psychiatry at the University of Toronto, and I work at a place called the Center for Addiction and Mental Health in Toronto.
Great. And Sarah?
Hi, everybody. I'm Dr. Sarah Conley. I'm the Senior Manager of Child and Adolescent Services at NOCD, which is why I'm here today to talk to you a little bit more about the child and adolescent side of things. I've been doing OCD stuff for a really long time, it feels like. NOCD since 2021, and I've known Patrick for years and years and years. So he's part of the reason, part of the blame that we place for me.
I think blame is good. Yeah.
Right. More accurate. That's what I thought too. You're like, yeah. But yeah, I've been doing this for a very long time. So I'm excited to share some of the really good work that we've been doing here today. So thanks for inviting me, Patrick.
Thank you. Jamie, why don't we start with kind of an overview of the study that's coming out and what we have found in treating people, especially children and adolescents, with obsessive compulsive and related conditions via our NOCD teletherapy.
Yeah, so it's very exciting. So we have a study that's going to come out in a publication very soon, probably this month, hopefully. And so this is a study that we did of children and adolescents that we treated with exposure response prevention at NOCD. And exposure response prevention is a first-line treatment for children and adolescents, also adults with OCD. And so what we did is we analyzed the results we had from roughly the first about 2,000 people that we treated. So there was 2,173 people that were included in this analysis. And so what we did is we took a look at the results in terms of symptom improvement from their treatment. And we report them in this paper that's coming out soon. And so what we saw is that there were really good results that we saw for children and adolescents. And we saw that children were responding well, the adolescents were responding well, and also that people that started with different severity levels were responding as well too. So those that started with mild symptoms levels did well, people with moderate symptom levels to start with did well, and then people that were in the severe symptom range when they started also did well with treatment. And another major finding is that other symptoms that are very common that commonly go along with OCD, so depression and anxiety and stress, those symptoms also improve significantly with the treatment, even though for the majority of people, the treatment was focused on getting the OCD symptoms better. But because those symptoms are so often a part of OCD, that we saw those improve as well. So we saw really nice, kind of like pretty comprehensive improvements in a lot of symptoms in people with OCD. And then another kind of the last thing that I'll mention here is kind of one of the key takeaways is that we looked at the improvements and saw how kind of durable they were over time. So we looked at all the way up to about 54 weeks, so about a year, to see if people were maintaining their gains. And yes, people were maintaining their gains, and many people were actually continuing to get better, like all the way up to a year as well. So I'll leave it at that. That's a lot of information, but they're very exciting results, and happy to share them with you.
Thanks, Jamie. Sarah, Jamie just talked to us about exposure and response prevention being the main component of the treatment that we do here at NOCD. And we've talked a lot on the podcast about that for adults, but haven't delved as much into it for children and adolescents and families. And I'm wondering, could you tell us a little bit about the training and the work that we do to take ERP into the realm of working with children and adolescents and families?
Yeah, so we have a whole separate training module that our therapists will go through after they go through our initial world-class training with experts to learn about ERP for adults and applying it for adults. We take them through a whole nother level of training with children and adolescents, where there's hours and hours and hours that they learn how to take their base knowledge of ERP and tweak that to be applied with our entire network of members here at NOCD, which is as young as 5. And as you very well know, working with a 5-year-old is very different than working with an adult or even older teens. So we'll work very closely with our therapists to make sure that they have the ability to explain key concepts and provide education. So one of the very beginning steps of treatment across the age range. So every all the way down to 5 years old, all the way up through 18. So all children, adolescents that we'll see here. And then we'll take it further. And how do you tweak ERP? How do you involve play in ERP? We'll train them on that and give them some ideas for that. How do you work with making response prevention goals, which is the RP half of ERP, more specific and behavioral? How do you tweak exposures to get more generalization from kids, which is something that can be a more difficult factor of treatment for children when you compare to adults? So we look at what specific tweaks need to be made and really work to train our therapists on those areas in depth and in detail.
And then there's a family accommodation component in this.
Then there is totally separate from the work that we'll do with tweaking ERP. I shouldn't say totally separate, but an extra layer, we'll say it that way, where at NOCD, we have all family, all kids and adolescents have their families involved. And, it might be at different levels depending on ages, but families are expected and required to participate in our treatment here at NOCD. And we see that makes a really, really big difference because often family members are accommodating symptoms, which essentially means they are doing things to help make OCD feel better in the moment, but in the long run, it keeps perpetuating that cycle. So pretty similar to how compulsions function. Accommodations end up functioning in that same way. So we bring family members in and really coach them on what OCD looks like, how that works, how ERP works, and then create their own version of a treatment plan that runs alongside their child's ERP treatment plan to help change how they are also interacting with OCD.
And then similar to the work with adults we do, our child and adolescent training ends with some clinical advising meetings, or CAMs as we call them, like tests and mock sessions, right? Can you tell everyone a little bit about that?
Yeah, so we have test and mock sessions with our CAMs. And so we really have our therapists show to our advising team that they can demonstrate providing psychoeducation for children, providing psychoeducation for their parents on what OCD is, what accommodations are, how we're going to engage in ERP. And then we also have them demonstrate how to work with children to create a hierarchy, how to work with children to start to build insight into how the different components of their OCD interact with one another, what their fears underlying OCD are, what triggers that start the cycle exist for them in their lives. And then also have them demonstrate and model for us how they would take accommodations and break those down into meaningful steps to work with parents to reduce those accommodations, because that's not something that we just ask them to stop cold turkey. And that's what we'll run alongside the child's hierarchy, is that parent's accommodation reduction plan.
So, Jamie, with all of this training, I think that explains volumes into why we can get some of the results that we do in the studies that we have found. And like you said, how it goes even beyond the OCD, but through the breadth of stress and anxiety and depression and mood and everything. When you take a look at what we do compared to maybe other places where there's more of a general approach, what sets NOCD different or makes it unique in terms of what we do and the results we get?
Yeah, so one of the things that we saw in the study, and we also saw this in the adult study that we did when we studied the results of the first adults that we treated at NOCD, is that the treatment is a lot more efficient. So these results that we got, where we saw symptom reductions in about half the time that it takes for standard outpatient therapy. So standard outpatient therapy for OCD, that's exposure response prevention, or sometimes it's referred to as cognitive behavioral therapy, but it typically includes some kind of exposure response prevention part of it. It's typically done in an outpatient setting once a week. So it's usually, say, an hour session once a week. And the typical course of treatment would be about 25 weeks.
Okay.
Of that. So what we saw in the child and adolescent sample is that we were getting these results at a median of about 13 sessions. So 13 compared to 25. And then that came out to be about 11 and a half therapist hours. So that's even less than half of the number of therapist hours that is typically required to do once a week outpatient therapy. So it's a lot more efficient. And there's a few reasons why most likely it is more efficient. So one of the things, so in addition to the amazing training that the therapists get, is that they also get a lot of help in terms of supervision. So if there are difficult cases or just difficult scenarios that happen, then they can reach out and get help from somebody in the senior clinical leadership team to help them out, to troubleshoot. They have other therapist peers they can reach out to for help as well. And so that's one aspect of it, is having to do with a really good training, and then the support that the therapists are getting from so many other people at NOCD. So it's really like a huge team that can all help. And also then there's other things that are built into the way that we do treatment, and what's available for the members, the patients, and their families is messaging. So they can message their therapist. So the child or the adolescent can message the therapist, also the parent can message the therapist. And this messaging then can happen in between sessions, for example. So as opposed to a typical once a week therapy, where that may be the only contact that somebody has with the therapist, is that one meeting a week. And then if something comes up in the middle of the week, like they're having difficulty doing their exposure, the parent doesn't really know exactly how to guide their child on doing something, or how to maybe not engage in some kind of accommodation they've been doing for a while. Rather than having to wait a whole week to see the therapist, they might message the therapist if they have a question like that, and the therapist can get back to them within 24 business hours. So that can really help keep things moving along, keeping the momentum. You don't have to lose a whole week if things aren't working out that well. So I think that's part of it that makes it efficient. And then the other part is that in the beginning, then we encourage all of the members to do twice weekly sessions in the beginning. And so typically they might do that for, say, the first 6 or 8 sessions. It is a little bit variable, kind of depending on each person's needs, but typically that would be the amount of time or number of sessions they would do twice weekly. And so the twice weekly sessions then also allow that momentum to keep going, so that, again, you don't have to wait a whole week to come back. And especially in the beginning, we think that's really important, because in the beginning, it's around the time that somebody's setting up doing exposure exercises and setting up how to do the gradual response prevention. And this can be practiced in session. And so ultimately, we want to try to help the kids and the parents then be able to do a lot of these things on their own, because a lot of the work of exposure response prevention is done outside the actual therapy sessions, done as homework. And so if you can practice a lot in session, because you're having twice a week sessions in the beginning, it really gets that momentum going in the beginning. And so we've actually studied the effects of the frequency of sessions. We've seen that the people that do twice weekly sessions, as opposed to people if they've only been able to do once a week sessions, they're more likely to reach a full response if they do twice weekly sessions. And we've also seen that there's a relationship between the amount of time, like the number of days between sessions in the beginning, and the degree that symptoms are reduced. So the shorter the amount of time between sessions in the beginning, the more the symptoms are reduced. And so all those things go in. There's probably other factors too, but I think all those things really kind of contribute to making it a pretty efficient treatment.
That front loading of ERP is so very important then.
Yeah, exactly.
I would argue, especially with parents and families. Sorry, Patrick, front loading.
No.
Because there's so much more that you're needing to juggle with that addition of the child and the parent and the accommodation plan and the ERP plan. There's even more setup than there would be with an adult member. And so having that extra time and front loading those sessions gets everybody going on that path, and really spurs that behavioral change earlier on for everybody in the system.
Yeah. I wanted to ask you, Sarah, specifically on education, because there's a couple of components that are really important there. Number one, Jamie mentioned about how we do case consultation groups, and you help run those and just a review. So we are not a train and dump society here at NOCD, right? Could you talk a little bit about that and the ongoing case consultation and work we do?
Yeah, so we're not at all train and dump. So I was doing quick math, adding things up in my head as we're sitting here. We offer more than 20 hours of just child-specific training, and all throughout that process there's opportunities to reach out and connect and have support through that. And then even once they have gone live with our child members, completed all of that time and are actively serving our members, there are multiple specific case consultation hours a week that are focused on children and adolescent. And we encourage folks to come sit in on those as they're newer clinicians at NOCD, to start hearing what kind of questions are being asked, what barriers are others running into. So we encourage that, and then leave those hours open and protected for child and adolescent questions specifically, so everyone can come and get support in them. And then not just that, but I have so many questions that come through Slack or email or individual one-to-ones for more complex cases that not only myself but other clinical leadership members will offer as well. And so we don't expect anyone to just be off on their own here at NOCD, and are not helping them to make sure that training gets solidified in a meaningful way, and that they're able to reinforce what they have learned, actually putting that in practice with members and having support throughout that whole process.
Thanks, Sarah. And I wanted to ask one other piece, because I think, what you two have discussed is so important. And I want to go back to the families a little bit. Can you spend a moment, Sarah, just talking about the role of families and accommodations, in the sense that we don't blame families for doing the accommodations. They don't know until they know, what OCD is doing and everything. So just wondering if you could talk about how we can introduce that to families to help them really buy into ERP, so that they will be an active participant in the experience.
Yeah, one of the main things that we lead with, and we train all of our therapists to lead with, is normalizing and validating that accommodations are a very, very natural reaction and response to anxiety, whether that be, from OCD or another anxiety presentation. And parents want to make their children feel better, which makes a lot of sense. And giving accommodations is the quickest way to get them to feel better. Just like often doing a compulsion is the quickest way to make yourself feel better. The key is that comes with the asterisk of in the moment. And that's the part that parents don't know until they know. They don't know how OCD works, and how reinforcing by giving in and giving the accommodation does make everything feel better and more calm in that immediate moment. But in the long run, it does not. And OCD grows and learns, hey, like, we can get mom to do this for us. Let's go talk to mom. Mom's going to help make this go away and get better. And so we normalize that for parents. We teach them and show them how this is a very natural reaction to anxiety, that the statistics are in the very, very high 90s for how families accommodate and how frequently that happens. It happens across subtypes of OCD. Not one subtype is immune to having this. And so we teach them about how normal it is, what the patterns look like, why it feels okay and helpful in the moment, why it's often hard to find other options, and validate throughout that whole process, and give them the knowledge to understand why this hasn't worked, why it's not their fault, and what they can do instead. Because often the what they can do instead is the missing piece, right? They start to recognize after a while, this isn't working. OCD's still here. Things are getting worse. There's big reactions and feelings when I try to stop doing these things. But what am I supposed to do instead? I don't know. And so we create that missing piece to the puzzle for them.
Makes a lot of sense. Jamie, did you want to throw anything in on that as well?
Yeah, no, so we were describing that. I was thinking about, those situations where, the kid is just begging you for it. As a parent, like, how do you deal with that? Because it's so instinctual to want to make your kid feel better. in that moment. And it's going to feel so hard and unnatural in the beginning to hold back and not do it. And so giving parents tools to be able to do that, and, even thinking about potential situations that can come up so they can preempt it and already have something in mind how they're going to handle it is so important.
Yeah. I'm thinking of the interview we did with Liz Tronson when she was describing when Chris was in the throes of OCD, what it did to the family, and how she adjusted, and I even asked her about, Chris has a sister who doesn't have OCD, and she described how difficult that is when one child is needing so much attention with the other, and how do you make it equitable across hand? It is not an easy thing to manage in these families whatsoever. Moving forward, that Jamie, you talked about our protocol, but if people are more on that extreme case, obviously there are higher levels of care. There's intensive outpatient programs, there's PHPs, partial hospital, there's even residentials. But one of the unique things we might be able to do at NOCD is even go beyond 2 sessions a week and work out with families, being able to do something more custom, maybe even up to 5 sessions a week. And could you talk about like where you might differentiate some higher levels of care into what we need to do individually, and how we can help people maybe navigate away from some of those potentially?
Yeah. So there are definitely situations where people need to do a higher level of care. Higher level of care, for those of you who aren't aware of it, in OCD, sometimes people, given the treatment resistance, that they haven't responded that well to other forms of treatment like outpatient, normal outpatient therapy, or medications, or a combination of such, they might need to do something like a residential treatment center program. And that's where somebody goes through a program where essentially they stay there overnight, and they could be there for many weeks or sometimes months. And sometimes that's necessary for really, really extreme cases where it's almost impossible not to do compulsions, and they need help pretty much 24 hours a day. There's also higher levels of care that are called, for example, partial hospitalization program, which people come typically 5 days a week, and they might come either all day or 2/3 of a day or half a day or something like that, and then they end up going home. But it's a very intensive treatment. It's like multiple hours each day. So that's another example of a higher level of care. So there are some situations that people need that, and for extreme cases, then that's often the case. But not everybody needs it, and for severe cases, some people they may benefit from doing that, but they may also benefit from doing other more flexible or intensive programs or outpatient programs, kind of like what we have available at NOCD. So, for example, what we've seen just empirically in our results is that that group of people that started with severe symptoms, they got substantially better, and their improvements. So the average improvement wasn't quite as good as the moderate range, but it's still actually quite good. And so there may be some people that may have otherwise needed or been referred or recommended to go to a higher level of care that might actually do quite well in the NOCD treatment, because twice a week might be enough in the beginning. And as Patrick said, then we now have the flexibility of designing some treatments that are even more frequent than that to meet their needs. So there's a possibility that it may kind of save all of that extra time and cost. Those treatment programs are quite costly by doing NOCD treatment, because it can be very effective for even severe people.
Jamie, obviously, as a psychiatrist, medications can play a role in OCD treatment. And I was wondering, sometimes we'll get questions about medications for children and adolescents and the role of meds there versus adults. I wonder if you could touch on that a little bit.
Yeah, so medications can be very effective for people with OCD, so adults and children and adolescents. And generally, medications in children and adolescents are considered second line, whereas the exposure response prevention and cognitive behavioral therapy is considered first line. And whereas in adults, medications and cognitive behavioral therapy with exposure response prevention are both considered equal first line. So, but really, there's a lot of very good evidence that the exposure response prevention and cognitive behavioral therapy is effective in kids. And because we know a little bit less about medication in children, kind of in general, because in general there have been fewer medication studies that are done in children, that I think that's why that got that recommendation. But nevertheless, medications can really help kids And some kids need to do medications. So they might need to do it because they may not be able to actually start to engage in exposure response prevention unless some of the symptoms come down a little bit in intensity. And so in that way, medication and exposure response prevention can be kind of synergistic or work together, because the medications rarely take the OCD away 100%. So a typical response would be a partial response with medications, still be very helpful, and it might bring the symptoms in an individual down a little bit so that they can then more successfully do some exposures that they weren't able to tackle before, or like really get a toehold on reducing some of those compulsions. So so we work together with prescribers. So we currently don't have prescribers at NOCD, but we then interface with them. So people that have their own psychiatrists that come in, or if their family doctor's prescribing it, then our therapists will be able to connect with them if there needs to be coordination of that care, and try to make it as seamless as possible to help with both angles of treatment that might be necessary for some people.
Sarah, treating OCD is tough. It's a specialized care. Working with adults takes a lot of training, and then adding children and families. And there are therapists who are resistant at first to working with children and adolescents. How do you work with people to show them the light, or even maybe say it better? How do you help motivate people to take that leap and showing them that, yeah, this therapy works across the board and it isn't just adults that this is helpful with?
Yeah, you're looking at one. So I started my career being like, nope, not kids, not kids. Nope, I'm going to be all adults. And now here I am. So when I'm working with them and training them, I usually start with that of like, hey, I used to be there. That used to be me. But especially with OCD and ERP specifically, we know that there's such a latency to care, and for care to be the right kind of care that people receive in order to make a difference and reduce their symptoms. And so I'll also share that and share how fun it is to work with kids through ERP and how much of a game that you can make it. And right, like I get to spend all day talking about OCD bullies and monsters and protectors and coming up with cool ways to fight back against your bully and talk back against OCD and show them how wrong they are. And I'm in like who can do it grosser battles, which note I always win because I have like zero disgust threshold. I was born to be an OCD therapist.
You're pretty gross. I can say that personally. Yes.
I am pretty gross, right? So I tend to win those battles, right? But showing our therapists some of the realness behind that and how fun it really can be, and how you can just show up as a fun human. Like I baked like monster cookies with someone once because we were worried about burning our houses down. So we baked cool looking monster cookies, and awesome. We left one in there a little bit longer, and it was a little brown and crusty. So like fun things like that you can fun ways to think outside of the box and engage with ERP, but also be making such a profound difference in not only the kids and the family's life right now, but their future. And so just kind of giving them a light into what kind of positive impact you can make and how much fun you can have along the way, and then equipping them with tools to make them feel like tools and support to make them feel like if things go awry, I've got the help, I've got the support, I know where I can turn, and kind of making it okay for them to express their anxieties around it and having some solutions for them. I think all those things together really has been able to successfully change some folks' mind who have been more hesitant about giving this a try and showing up for the children and family members of NOCD.
A lot of our Get to Know OCD podcast interviews have been with adults, and there's always the choice of an adult to come on and talk about their symptoms and what's going on. That may be a little bit more difficult for families. Do they want to have their child out there talking about things? I'm wondering, though, if the two of you might be able to just give us some feedback about things we've heard or seen that have, in terms of the lives changed in the work that we've done with the families and the children and adolescents who have OCD?
Sure. Yeah. Jamie, would you like to start, or you want me to start?
Yeah, well, why don't you start? I mean, you have more experience working directly with them than I do.
Sure.
But I
Sure.
have some cases that I've worked with. Yeah.
Yeah, one I can think of off the bat. I still see her. I still check in with her during more of maintenance sessions, but she and her family, she's actually highlighted, so if she sees this, she'll know who she is. She's highlighted in one of our training materials, talking about how well rewards and consequences worked for her through her treatment. But she started at a much higher level of care and has worked all the way down through the levels of care, and is now able to go to school when she wasn't before. She has really big feelings about things in her space being how she needs them and how she wants them to be. And now we're able to let people in her room freely, herself, her younger cousins, her younger brother, her family, everybody can be in her room and in her space, and that's okay. And not only was this, causing a lot of difficulty for her, but it was a lot for the parents to manage and to keep managed and keep so much room and space around everything. That she genuinely was having trouble functioning with friends, having trouble functioning with family, couldn't be at school in meaningful ways. And now all of that is different for her. She's going to middle school in and able to, transition quickly from class to class. She has 3 minutes to get from one class to the next and put things in her locker and that would have just been impossible for her before. It was not an option to do things that quickly. And now she absolutely can. No problem. So she's been a very, very big success there.
That's fantastic. Jamie, did you have something?
Yeah, I mean, I can. There are a couple different ones. So one is somebody who I didn't treat. I treated his father actually. So, but his father, who had OCD and anxiety, brought it up with me one session and said, that he wonders if his kid has OCD. So, he described the behaviors that his kid was doing, and he was doing a lot of rituals. He didn't really know what his kid was doing at first, and his kid was quite young. He was 5. But he was doing certain things with his toys and lining them up near his closet, and and the dad didn't really know why he was doing it, and he wasn't really he didn't seem like he was telling his dad very much why he was doing it. But eventually he kind of found out that he was afraid of something, because he would come into their bed every night, and that kind of started when he was 5, and he wasn't doing that when he was younger, and he was very afraid of something in the room, and then it was somehow linked to what he was doing with his toys, and then he eventually kind of pieced together that he was doing it, or his kid says something about how he was doing to try to prevent something coming out of the closet and getting him at night, and he thought that he had to line his little trucks up just in the right way to be able to do it. And so it sounded like, but he wasn't. I didn't see the kid; he wasn't my patient. So I helped the father find a therapist in his area to be able to evaluate him, and so he found a therapist, and then she started seeing him, and really great therapist, and was working with them. And I don't know all the details of what they did, but he was getting a lot better. And then so I heard through the father about how much better he was getting, and he got to the point where he was not doing that at all, and he was able to sleep in his room, and he didn't come into the parents' bedroom. And the therapist, worked with him and his wife to figure out if there's anything they were doing, to allow some of this to happen. And there wasn't a lot of accommodation. I mean, my patient knew a lot about OCD,
Sure,
and so he knew not to give reassurances about things. But he didn't even really know exactly what was going on with his kid, because his kid wasn't able to verbalize it that well. But eventually the big thing they did is they had to help him not go back into it, not go into the bedroom, and when he wanted to go in, to be able to gently redirect him back to the bedroom. So that was kind of hard, but they were able to get through that.
Wonderful. One thing for the two of you also is a lot of times there's the guilt factor where parents will think somehow they gave their child OCD. It's their fault
Mm-hmm.
that they have this. How do you address that with families to help them deal with their own feelings of sadness or frustration or guilt that they might have around this diagnosis?
Yeah. My first step is give space to hear it, to listen, to validate, and then educate on that's not how OCD works. Like, yes, there is a genetic component, but we're not giving it at all. It's also not your fault that it was being perpetuated by accommodations, and also highlighting, especially for kids, how quick of a fix it can be when the family really commits to changes, and I'm not meaning quick within like a matter of days or weeks even, but like relative to the amount of time that they are suffering with these symptoms, it's a pretty quick fix. And so holding the space for it, and then giving that education of this is not anyone's fault. OCD doesn't operate, but like, because it's someone's fault, there's nothing that you could have done differently to prevent OCD from showing up like this. And however, there is tools that you can use to help not let it take over your life or your child's life like this again. So let's focus more on that. And that's something that you can absolutely do successfully. And I've seen families do successfully with those new tools, is even when OCD tries to pop back up later, right? When this links back to that other success story, is being able for the families to talk through. And I just had this happen in a check-in case as well, where OCD tried to show up in a new way for the child and family. The child shared it with the parents. The parents were like, all right, well, what are you going to do about it? How are you going to do your ERP? What? And then here's what I'm going to do about it. Here's what I'm not going to do. And so once they have those tools, that makes that really big difference. But allowing them to express their concerns from the beginning can be helpful. Yeah.
Jamie, anything else on that?
Yeah, I mean, speaking to the that Sarah brought up, the genetic piece of it too. So yeah, I mean, genetics do seem to contribute to OCD, but it's not everything, and so like sometimes people might feel guilty that they, like, genetically they may have contributed to their kid, and it's possible, but the way that we understand genetics, certainly we know that there's not one gene that causes OCD, and the genetic liability is likely made up by many small contributions. So small contributions from many different genes. And so in any individual person, though, we don't know in that person what proportion of the development of OCD came from genetics versus other things, because there's other non-genetic environmental contributors that seem to happen as well. And so that the bottom line of that is that you don't actually know how much, even if you have OCD yourself, you don't know to what degree, if any, genetically it may have contributed to your kid developing it. The other thing too, from some of the studies that allow us to understand about genetic contributions, many of these are done with twins. So twins that are identical twins, so monozygotic twins, and twins that are non-identical twins that share about 50% of their genes, that are called dizygotic. And from the twin studies in OCD, it looks like, first of all, that the liability for OCD symptoms is explained by roughly 50% by genetics. And then most of the other explanation for it is what's called unique environmental effects, as opposed to shared environmental effects. So shared environmental effects would be things that the twins would experience similarly, whereas unique would be things that would happen to them separately or individually. So you can think of like a shared environmental effect typically is something that might happen in the family household, where the way that the household is for some reason, and that could be something like maybe parenting style, or it could be other things about the environment that the parent may have been like responsible for, or that if there was a lot of shared environmental effects, then that might come from that setting. But in OCD, it seems like there's very little contribution from shared environment. It's mostly from unique environment.
Okay.
That kind of other 50% of liability on average comes from other things, and unique environmental events are things. There could be a lot of different things. It could be stress. It could be, for some people, trauma. So in that way, I think that can sometimes help parents then see, okay, you know, some of it might be genetic, and also to help parents understand, like, you can't really help the fact that you have those genes yourself
Yeah,
too.
right.
Yeah.
And then the rest of it comes from things that are probably not things that happen in the household.
Sarah, I'm wondering if you could talk a little bit about the differences in OCD between children and adolescents. Or are there differences? Are there differences in symptoms? Are there a difference in presentations that we see between the two?
There are and there aren't. So there aren't in the sense of you still see obsessions, you'll still see compulsions, you'll still see across, right, all the subtypes that you see in adults, you'll see with kids. There is a little bit of variation in how the subtypes present, in that like children are more likely to experience harm related concerns than adolescents. Adolescents are more likely to experience more like sexuality or religious scrupulosity concerns when
Okay.
compared to children. So slight differences there, but across the gamut, subtypes not are the same. Where you do see kiddos start to differ more from adults is their insight levels and what they're aware of and what they're able to report. So they may have less insight or awareness into their obsessions and may be able to report a lot more on their compulsion. So they may need more help kind of building and connecting the dots between the different processes and aspects of their OCD. Another difference tends to be how reliant they are on other people to help manage their OCD. Now, that's not exclusive. We see some adults who are very reliant on partners or parents to help their OCD be managed. But in kids, that tends to be a pretty common difference, is how involved and family members are in helping them manage their OCD. So that's another big factor that we look at and that we focus our training around here at NOCD.
Both of you have talked a little bit in your answers about just not being able to function the way that people without OCD function in day-to-day life. What does not functioning look like? And what are some signs that parents might notice that their children don't seem to be functioning the way children without OCD are functioning?
Yeah, I would say not being able to do things that they used to in the ways that they used to is a red flag. Not being able to like go to school and focus and engage, not being able to do homework in ways that they used to, getting much more irritable or maybe more upset about things that seem pretty small or that wouldn't have bothered them before. That might be a sign that anxiety is around or that compulsions are being blocked. Needing more and more support in areas where they didn't used to. If I need you to check my homework over and over and over again, and I used to be pretty independent in my homework, that might be a red flag that something's going on. If I'm needing to repeat things over and over or wash hands over and over again when I didn't used to, or it didn't used to bother me. And it's not just, because I'm told I should wash my hands. It's because I'm really upset and I'm stuck if I can't. Those are some things that parents should start to look for. High levels of upsetness, stuckness, differences in things that used to be okay and now they're not. And then that irritability and an increased mismatch in how they're presenting emotionally with what the situation is would be some key things for me. I don't know if Jamie, there's more from you.
Yeah, I mean, and I can think of, I was thinking about adolescents. And so with adolescents, it might be that they're starting to avoid certain things, like maybe they're avoiding being around their friends when they didn't have any issues with that before. And even out, adolescents may not be that verbal to their parents about why they're doing it. And so the parents might just notice that they're not going out with their friends as much, or they might not be, for example, wanting to walk to school, or like wanting to go on public transportation. Obvious things like washing and checking and things like that are a little bit more observable. But I think the other kind of big area to think about is like, are they avoiding something? Are they not doing something they were doing before, like like they're being around friends or being out in public in some way? And then also grades too. So were they doing reasonably well in grades, and all of a sudden like their grades start to drop? You don't have other kind of good explanation for it. Because they may be distracted in class, or maybe avoiding going to class or late to class, or delayed in how they can do their homework. Homework takes too long, so they're doing too much checking of it, etc.
And I've even seen children be thought to have ADHD instead of OCD because they're not paying attention.
Mm-hmm.
And this is where a good differential diagnosis is really important. If you're seeing those changes in behavior, make sure that you reach out to a specialist who really knows what they're doing and can diagnose these things and get someone on the right path, because there are good behavioral treatments for ADHD and for OCD, but you want to use the right one for the right condition. That's for sure.
Absolutely.
Great. Before we wrap up, Jamie, what do you think are really the most important aspects of what you want the OCD community to really take away from the study that we've just published?
Yeah, so there's, one thing that we haven't even talked about the importance of the study and the work and treatment that we deliver at NOCD is the fact that it's a virtual treatment. So it is a video therapy treatment. So it's one-on-one with therapists, but it's done remotely. And so in addition to this study being the largest study of OCD treatment to be published in general, it's also, of course, the largest study of virtually delivered treatment or remotely delivered treatment. And so
Very good.
Even though there have been other controlled studies, there have been many now of children and adolescents, and there's also been a lot of adults as well, showing that this remotely delivered treatment can be very effective, and for the majority of people as effective as in person. That in children, most of the other studies, these were done in controlled studies. So what we did and what we're reporting on, it's not a controlled study. This is just the natural clinical treatment that people underwent, and then we just did analysis of the outcomes for it. So this is a real world sample, which means that these are all the people that come into NOCD and get treatment, rather than being selected or having inclusion and exclusion that are typical of research studies. So now we can say that this virtually delivered treatment in this very large sample, a real world sample, is effective. So I think it can really help the field feel more confident about this type of treatment being delivered virtually and it being effective.
And Sarah, what are you really most proud of accomplishing so far here with NOCD and getting this child and adolescent training and treatment up off the ground?
I'm mostly proud of how much more willing and comfortable our therapists are to work with and treat children and adolescents, because a lot of times people are able to, indicate, I don't want to work with children, and they don't work with children, but then that makes it children not have as much access to care and treatment. And so that's what I'm most proud of, is being able to make all of the therapists in our network feel more comfortable and confident in delivering that treatment, and thereby increasing access to care to the children and families who need it.
I want to add something too that I think is really important about just in general treating children and adolescents, and it's really encouraging that so many of the therapists then get to experience that and do it, because many of them will find that it can be quite rewarding. And another way that it can be rewarding is that when you treat a kid early on, if their parents identify it and bring them to treatment, within, sometimes it might be like within months of the symptoms developing, or even like within years. In the big scheme of things, that's not very much time. And when a kid is getting better, you're saving all of those years and often decades that somebody would normally suffer before they get treatment, because unfortunately a lot of people don't get treatment when they're kids, and they have it for so long, and it can affect their lives in so many ways. They suffer from it so many years, and it can affect their psychosocial development in different ways. And by treating kids, you're preventing that from happening and preventing years and years of suffering.
Awesome. Well, I want to thank both of you for joining me today on the Get to Know OCD podcast. It's been a very quick hour, actually. I'm thrilled, though, that the study is coming out through NOCD, and we've shown that teletherapy is an effective treatment for children and adolescents and adults, from what we've shown in the past. And so thank you both for the work you've done, Sarah in training, Jamie in organizing everything and getting the study out. Your efforts are Herculean and appreciated very much.
Thank you, Patrick.
Of course. Yeah.
And Thank you all for joining us on the Get to Know OCD podcast. If you liked what you heard today, you can subscribe on the NOCD YouTube channel, or you can get this wherever you get your favorite podcasts. And if you're looking for help for OCD or related conditions, go to NOCD.com. We have great therapists who are expertly trained in OCD. We do a rigorous interview to get people in. We do go through tons of training with folks. There's testing and mock sessions that we do before we release people to the live training. And then we have continuous consultation going on afterwards. We do not train and dump. We want you to get the best service possible, and we want to continue to try to build that service for you. So check us out at nocd.com and let us see what we can do for you today. Thanks for joining me. We hope to see you again on another episode soon.